Hey everyone, welcome to Prune Belly Insiders, and today I have a special guest on with me. I'm your host, Michael Adams, and today I have Dr. Robert Debbs, a maternal and fetal medicine doctor, and this is a real special doctor because it's actually the doctor who delivered me. Everyone, please welcome Dr. Debbs.
How's everybody doing?
Good, how are you doing today?
I'm great. It's awesome to be here.
I just want to say this is an amazing privilege and honor to have you on my show.
Well, it was interesting to connect with you after so many years, and that's rare for somebody like myself because I deal with mostly babies before birth. So I get notes from moms periodically, but I rarely get to meet kids when they're already grown up. So this is cool.
Yeah, I heard how much you did for me and my mom when she was pregnant with me, and I just had to meet you.
That's great.
So, all right, let's get right into it. What made you choose maternal and fetal medicine?
So that's a great question. So I was always when I first wanted to become a doctor, I wanted to take care of families from birth to death, essentially, and I thought I was going to be a family doctor. And then through my training and experience and getting exposed to different things, I learned that I really loved babies and obstetrics because there was a lot of really cool stuff happening when I was training. Like we were learning a lot about how to treat babies inside the womb as individuals, as opposed to just somebody who's hanging out being carried by their mother, but actually as an individual that may need treatment of diseases before they're born. And I thought that was a really cool thing. And there was a lot of stuff evolving in the 1980s when I was in medical school. And so it became like my life's passion.
That's great. That's great. So, what advice would you give a pre-med student who wants to go into your specialty?
Well, first, like any specialty, when you're in pre-med, I always tell medical students when you're training to approach every rotation as if that's what you're going to do for your life, because you'll never really learn what you love unless you dive deep into each specialty, even if it sounds like the most boring thing in the world, because there's a lot of specialties in medicine that are pretty boring and to some people, like certain fields like pathology, but that may be very, very exciting to some people when you get into it. So go at everything as if that's what you want to do. And then over time, you're going to learn what makes you want to wake up every morning. Like it's very challenging being a medical student. It's a time commitment that's is equal or surpasses almost any profession, and it takes a lot of dedication and a lot of work. And so when you know that, like, you can't wait to wake up the next morning to go back to work to do something, then that that's probably something you want to do. So that's how I felt with maternal and fetal medicine. And so if somebody feels that way about delivering babies and obstetrics, then that's the field you want to go into.
So, almost like that saying, if you do what you love, you never work a day in your life.
That's exactly true.
All right. So, what signs do you look for when diagnosing Prune Belly Syndrome?
Yeah, so people come to me for a variety of reasons. The most common is that a lot of general OBGYNs refer people to somebody like myself to do routine and evaluation of how a baby's developing. And so we sometimes just find it by accident when we do an ultrasound and we see all the signs. And sometimes people are referred to me because they have an ultrasound of their pregnancy somewhere else, like at a radiology place or another doctor, and they come and they see something that's abnormal and they're not sure what it is. And so they refer them to me to figure it out. And then we start doing the testing and evaluation, and then we make a diagnosis.
Okay. And after they're diagnosed with prune belly, what is some of the procedures or treatments you can use to help keep the baby alive?
Yeah, so Prune belly. The term is sort of it's a larger group of diseases that describes what some of the side effects from urine not being able to get out of the bladder and the urinary system, and so there's a bunch of reasons why that may happen, and there's a lot of things that we have learned since you were born, actually. Um, so we used to think that the majority of these were caused by a blockage in the urethra, the tube that empties your bladder. And it was majority we thought were caused by extra flaps of skin in the urethra that never dissolved when they were supposed to, called posterior urethral valves. And that was what we thought caused the majority of these. But we've learned over the years that now there's actually a lot of different causes. So when urine backs up into the bladder and it can't get out into the womb, the fluid, which is urine, can't get out into the amniotic sac. And a baby needs to breathe the urine, actually. The amniotic fluid is predominantly urine. I know people freak out when they hear that they've been swimming in urine for 9 months in their mom's tummy, but that's exactly what happens in pregnancy. But you have to breathe that fluid in order for your lungs to develop. So if you don't get the fluid to breathe in your lungs, for your lungs to develop, then you can't breathe at birth, and you don't survive. So in what we call today, we term it LU-LUDO, or lower urinary tract obstruction, which leads to Prune Belly Syndrome when it's untreated. But there's also Prune Belly Syndrome that can be caused by, we now know that there's multiple genetic defects that cause it. And those genetic defects don't allow the nerves in the belly and or the bladder to form normally. And so sometimes it's not an obstruction at all. Sometimes it's just that the nerves didn't form right. And so the bladder doesn't ever contract and the urine never gets out of the bladder. Or in some people with prune belly, the abdominal wall, the muscles don't form right because there's a genetic defect that they found. So now we know that there's about 4 different genes that can cause this. So there's a variety of different ways that this happens, but basically there's a variety of different outcomes. Like some kids, like you, the urine wasn't getting out of your bladder when you were inside your mom's womb, and the fluid was too low for your lungs to develop. So we had to try and bypass the urethra and allow the urine to get out of your bladder into your mom's amniotic sac so that you could breathe. And when you were born, your lungs would work. If we didn't do those procedures, meaning we put a shunt in to drain the fluid from your bladder to the amniotic sac, and that's called a vesico-amniotic shunt. If we didn't do that, then you wouldn't have been able to survive after birth. The other thing that happens is that the urine backs up into the kidneys and it causes chronic kidney disease. I don't know anything about your medical history now, but I assume you may have some kidney issues.
Yeah.
That's a very common thing that people get when they have this disease. But sometimes the kidney disease is so severe at birth because it was untreated that your kidneys don't work at all, and you either have to get dialysis or get a kidney transplant. I apologize, my dog is not interested in this topic. But yeah, so there's a variety of things that happen, and it's a very rare disease, as you know. 1 in maybe 50,000 pregnancies or something in that range, and a lot of times it's caught too late, so the lungs and the kidneys don't function good, and so the survival rates for some people aren't very good. But I'm thrilled to see that you're here today.
Thanks. Hey, I probably wouldn't be here today if it wasn't for your handiwork.
Well, I mean, you never know how things are going to work out. Sometimes in medicine, there's a lot of unknowns, and there are certainly, all we can do is say what could happen, and what we might be able to do to fix things. But sometimes nature works its way out without our intervention. So sometimes nature has a different path that we're not, without our help. But yeah, I mean, I think that in your case, it would have been very challenging for you to be here today if we didn't do those things.
Yeah. Okay, so what happens after birth with the prune belly baby after it's born?
Sure. Yeah. So once a baby's born with something like that, they have to get a complete evaluation to see. Well, first in the womb, we actually do tests to see how the kidneys are functioning, and we have some indirect ways to see how the lungs are working. So the two major issues are the kidneys going to function, because you need your kidneys to filter toxins out of your body? Can we get the urine out of the bladder, or do we have to do surgery of some sort to divert the urine from out of the bladder because the bladder is not working? Or do we have to reconstruct the bladder, or do we have to connect the kidneys to intestines because the bladder doesn't work, and so you have to get the urine to come out through a different way? So there's all kinds of different things that can be done depending upon each individual, and each individual is very, very different. So for instance, if yours was caused by a problem where a lot of these are caused by a flap of skin near the prostate gland in the urethra, and if it's caused by that, then they can remove that with a telescope, and then if the bladder functions enough, then the urine may come out normally. Some people, because the bladder gets so stretched out during the pregnancy that the bladder wall just doesn't work anymore, they either have to have their bladder reconstructed, or they have to have the urine diverted and come out a different way. Again, I don't know your medical history, but I assume you may have went through some of that when you were young. So they have to do an assessment after birth to see how the bladder is working and how your kidneys are working. So they do a bunch of tests looking at that. The first one is just to get a picture of what the urinary system looks like after birth. So they do a test called a retrograde cystogram, and what that is they put a catheter through your urethra. In a guy, of course, it would be a penis, and they push dye up inside, and they take X-rays, and they can see your entire urine system from your kidneys, ureters, down to your bladder and your urethra, and we can see what everything looks like. And then they do a test to check the function of the kidneys, and that's a different kind of test. That's usually either a nuclear test where they inject your blood with isotopes, and then they see how your kidneys are functioning, if they're functioning good or not. If the kidney function is bad, then the question is can you is there enough kidney function to survive without getting dialysis or a kidney transplant? And that depends upon how severe the kidney disease is. So a lot of the things that are done depends upon each individual, because it's different for every single person. And then you got to deal with because the urine didn't come out, your belly is twice as big as normal, because the belly wall has no muscles that work well. So that's where the word, or the description of prune belly comes from, because it's the skin and the muscles are stretched out so much that it looks like the outside of a prune, and it's very lax or soft, and so that creates a whole set of other issues where multiple surgeries might need to be done to fix that. And again, I don't know actually what you and your mom went through after the birth, because once I hold a baby, I hand it off to the pediatricians. I get a little bit of follow-up that, okay, the kidneys are working, the kid's surviving, but what happens after that, sometimes I don't hear about. So you can tell me what your mom told you.
Yeah, it's real rough.
Yeah.
But yeah, I've had vesicostomies. I've had two kidney transplants. I've had a couple abdominoplasties and a major bladder reconstruction in 2016 that worked, but didn't have the best outcome in terms of it gave me what I think Chop called it amplified musculoskeletal pain syndrome.
Right.
Which I'm talking to a couple doctors, because I know that this is another rare condition, but I think it could be, I forgot the actual name for it. I know the abbreviation is MALS.
Right.
Which I think it might be. but
Yeah, those are all, so that's the other thing is that, anytime you have one set of problems, the treatments can lead to other set of problems or diseases later too. So, and pain syndromes are one of those. But the major things are, of course, you need some form of kidney function, or in order to get rid of the toxins in your body. So, fortunately, kidney transplants in babies are challenging because it's hard to find kidneys to donate to babies, because it's just a very challenging thing. So babies have to go through many times dialysis for a while, to filter their blood, and dialysis in babies has a lot of potential complications. So there's a lot of really bad, difficult roads to get past to get to the point of a kidney transplant. How old were you when you had a kidney transplant?
I had one at 3 years old and then another one at 13.
Okay, so you probably went through well, most likely babies go through either what's called peritoneal dialysis in their first year or two. So that was probably a very, very rough road for you and your mom.
Actually, my parents said I was able to thankfully avoid dialysis.
Oh, good, good, good.
Yeah.
Yeah, that means that we were able to save enough kidney function, so that you were able to survive long enough to get a kidney transplant, which is the goal in
Yeah.
this situation.
Yep. So, how many females are born with Prune Belly syndrome?
Yeah, so that's a great question because the majority are males, and that's because there's some theories that a large number of these occur from an extra flap of skin that comes off of the prostate gland, and sometimes it's caused by abnormal muscle cells in the urethra itself, and so there are females who have a similar syndrome that's usually caused by a stricture or a blockage in their urethra called urethral atresia, but it's very rare. So it's the majority of kids are male. 9 out of 10 are male for that have this, but it does occur in females in very rare situations. It's much more difficult in females, because their urethra is much shorter, and it by the time it's found in females, a lot of times there's not a lot of things that you can do about it.
All right. Now, do you think a doctor ever looks at those statistics and then won't diagnose someone with prune belly due to the fact that it's majorly in males and one could be female?
Yeah, I don't think that. So the word prune belly, I mean, usually we look for the reason why urine's not getting out of the bladder. So prune belly is a sort of a global term that describes all of the things that can happen for a variety of different reasons. But we now know that prune belly itself can be a isolated disease by itself, meaning that you can have a genetic mutation that causes the muscles in the bladder, the urethra, and the abdominal wall not to form right, and so it's a primary disease. But then prune belly can develop secondary to a mechanical obstruction. So, for instance, if a female has the urethra that doesn't form, that's called urethral atresia, then she can get all of the symptoms that you would get with prune belly. So it's not that somebody's not doesn't want to diagnose it in a female, it's that they're looking for the cause. And when you see a female, the causes are much different or much less than they are with a male. So they use different terms. They basically use so the term that's used today is like I think I mentioned before, it's called, we didn't use this years ago, but now we use the term LUDO, or lower urinary tract obstruction. And then the question is can we find out why the urine's not coming out of the bladder? So today, one of the things that can be done is, which is different than, you're how old now? I forget.
21.
21. So um, today we're a lot of times we send people to CHOP at the Center for Fetal Diagnosis and Treatment, and they stick a telescope inside the woman's uterus during pregnancy, and they can actually visualize the urethra and see if it's a urethral obstruction or something different. And if they find a urethral obstruction today, there's some experimental work to actually laser the blockages to try and fix it without having to use shunts and stuff. So the treatments, the experiments today are very different than they were back when you were born. The approach to it's very a bit different. But overall, females don't do as well as males because the ability to fix things is much less.
Okay. So, just out of curiosity, was I your first Prune Belly patient?
You know, I don't. If it was 21 years ago, probably not. So I started becoming a high-risk pregnancy specialist back in 1994. And you were born what year?
2000.
Yeah, so back in 1994, so I saw a bunch of patients before you were born with that. Back then we didn't have this special center at CHOP actually. I was from Pennsylvania Hospital in Philadelphia, from the University of Pennsylvania Health System. And I don't remember how your mom got to me, but our group was doing these treatments and shunts to fix this problem. And one of my mentors was a guy named Stuart Weiner, or we call him Bud Weiner. He's now retired. And he trained me how to do these shunts and stuff that we did on you. So there was a bunch that I did before you. But you were one of the successes. Not everybody works out so well, even though I know you had a rough road, but unfortunately some babies don't survive.
Yeah, I was actually lucky enough to find a network of Prune Belly patients actually.
Uh-huh.
So we kind of just get together, support each other, lift each other up. It's filled with like Prune Belly patients and their parents, and even people still pregnant with Prune Belly. So I do know it's kind of rare, and not many make it. There's a lot more than I would think a lot of doctors would think, but I do know it's not many make it.
Yeah, what happens is that so we, if somebody comes to me and we diagnose that the urine's backing up and the kidneys are getting affected and the fluid around the baby is low, then we have to do an assessment in the womb to see how the kidneys are functioning. So what we do is we take a little needle under guidance of ultrasound, and I drain the bladder. I usually do it 2 or 3 times to see how the urine coming out of the kidneys is working, whether it's the kidneys are functioning. Because if the kidneys aren't functioning at all, then the chances are much less that we can help after birth, because like I said before, dialysis is really, really challenging. It's dangerous. There's a lot of kids who don't survive it, and there's a lot of and it's very hard to get a kidney transplant when you're born. So you got to get enough kidney function to allow a kid to survive long enough to get their kidneys fixed or get a transplant, which you were able to do. And so we do that assessment in the womb. So if we find that the kidneys aren't working, then parents have a very difficult choice. They have to choose, which way they want to go, and how much. I hate to use the word suffering, but there's, in your case, it's a rough road. I mean, it's not easy. It's very challenging. And of course you were a baby, so you probably don't remember a lot of those things when you were born, but just, hearing about as you get older and you see what you went through, you could probably realize what it was like for a little baby as well. But so those decisions are really hard for families. It's an emotional toll, and everybody wants to do everything they can to help a baby, but you also don't want a lot of suffering that may not work. That may not. All it does is prolong the suffering. So it's a really hard thing for some families.
Yeah, I think what a lot of people should look at is quality of life versus quantity of years.
Yeah, sure. Absolutely. I mean, yeah, absolutely. That's it. That's true for, I think, for anybody, um, whether you're a baby or whether you're an old person. Um, that that thought process is actually very true. There's a big, you know, there's a big ethical debate in my field. I think that society may actually, in some places, they undervalue unborn babies compared to older people for some reason, because they haven't been around as long, and so there's, we spend probably more than half of the country's money in healthcare on the last year or two of life, and we spend much less on babies with ear issues.
Yeah. So, what I know you said not many make it, but for the ones that do, is there a life expectancy on, what's the life expectancy of a prune belly patient?
Yeah, so that's a very variable thing because it depends on all of the factors that we talked about. Like, for instance, if you have really bad kidney function at birth, then the life expectancy is fairly short. And there's a number, I would say probably somewhere between 30 and 50% that don't survive more than a couple of years. So it's a devastating disease. There's no question, and I'm sure you've now your group that you're part of and the people you talk to obviously are all here. So you have what we call in medicine a selection bias, meaning that you guys are all around, but there's more than half of you that didn't make it
Yeah.
because their kidneys didn't work, or more importantly, the kidney thing is, even though it's serious, we can get around that by different treatments, but the lungs are a different story. So if you don't have fluid around your baby in the womb before 20 or 24 weeks, the lungs won't develop. And a baby's born and it takes its first breath and then it can't do anything else. And if you have no lungs, then unfortunately, there's not much we can do. There are treatments for a variety of different kids who have some lung function. But if the lungs don't grow, if you don't grow the tubes to breathe, then survival is not going to happen because you don't make it. Kids don't make it out of the delivery room. They're born, they take one breath and they pass away right away. So there's it varies depending upon how serious your particular problem is, and if somebody was able to find it and fix it before it became too severe.
All right. And how do you handle all the emotions with your job?
That's a really good question. Well, I think I try and have a really good relationship with all my patients, and I'd always tell them that my job is to give them accurate information based on the facts as we know them. Tell them what we can do and what we can't do, and help them make a decision about things that's right for them and their family. Because it's not about me and my family, and it's not about what my wife would do or about some other family, what they would do, because everybody's different, and everybody has a different outlook on life, and everybody can handle challenges differently. So it's emotional in the sense that I have families who they feel like when they get a diagnosis like this inside the womb, that, well, this was what was meant for me. God meant me to take care of a special kid who needs help in its life, and this is what I'm going to do. And they hit the challenge head on, like your mom did. And so the emotions are different dealing with a family like that than it is dealing with a different family who may feel like, they've been through too many hardships in their life for whatever reason, and they can't even think about the potential suffering that might happen. And they have a very difficult time coming to grips with anything that might be wrong with a child before they're born, and they can't cope with it. So my emotions then sort of transition into more of a therapist mode. I always joke with a lot of my colleagues and my patients that and then this is not a slight on women, but a lot of what I do is have to deal with women from the neck up. I'm essentially like a prenatal psychiatrist. Because and I'm not saying that people are crazy, but everybody has a different way they deal with adversity in life. And when you're pregnant, it's the happiest for most people. It's supposed to be the happiest time of your life. And you first asked me why I went into this field, and I know that many times in cases like yours, it becomes one of the most devastating times in their life, and somebody has to be there for those people to help them cope through that situation. And it's the most difficult thing that almost anybody can deal with, is learning that you now have an unborn child who may not survive. And you think about that, it's very different than you're told that you're like, I have a 95-year-old mom. She's still alive, but she's lived a great life, and I know she's going to pass away at some point, and we're going to celebrate her life. But it's a very different feeling than knowing that your 20-week baby inside your womb that's not even born yet may be born and then not live a day. So dealing with that kind of paradigm is not only emotional, but it can be devastating. It can incapacitate families for a period of time. So my job becomes not only a clinician to try and help them, but a therapist. And yeah, I mean, it hurts, but we have to we have to do everything we can to help people through it, and do it in a way that makes it right for them.
Yeah. So I know you were talking that Prune Belly has a genetic component. So my question is, what are the odds of a Prune Belly patient having a Prune Belly child?
Yeah, it's a great question. So it's low. So when you were born, we didn't know about the genetic mutations yet that were found later. Many of these weren't found until the last 10 years. So just as a background, after you were born, actually the some researchers in the United States first, they based on the National Institutes of Health, they had a project, and you may have heard of it, called the Human Genome Project. And if you want to read something really cool, it's an article published in a magazine called Science. So the Human Genome Project set out, and I think it cost something like $300 million or something. And they tried to identify the entire genetic code of the human body. And that started a revolution in the world, all over the world. And we learned that, hey, you know what? A lot of these diseases that we thought were caused by this were actually caused by a very small mutation in a gene. And the gene didn't allow a protein or an enzyme to be formed, and therefore the muscles in the belly didn't work, or the muscles in the bladder didn't work, or there's literally thousands of these now that we found. So in your case, they found 2 or 3 genes that are identified in about 20 to 30% of people with Prune Belly syndrome, and those genes appear to be what we call spontaneous mutations, which means that they happen by chance most often. So the risk of other kids in the family having it is low, but still possible. So it could be as low as 4%. There is a gene that is that's found as a it's a dominant gene, which means that if you have it, for instance, you yourself, 50% of your offspring might have something similar, but most people don't have that gene. And I think it's only under research type thing right now where you can get it, find it. But so the majority of the time, the risk to other offspring is very low, probably in the less than 4 to 5% range. So 95% of the time, it wouldn't happen again.
All right. Now, I actually posted about this interview before we started recording this to get some questions from like other prune belly patients in the audience and stuff like that.
Yeah.
So here's a question from one of the audience. Of course, I'm going to be paraphrasing here.
Sure.
Not every a lot of doctors I've seen has never heard of prune belly. So is there something that can be done to make doctors more aware of prune belly syndrome?
Yeah, so it depends on I guess it depends on what kind of doctors. So I'm a subspecialist. So I'm not just an obstetrician, but I'm a high-risk pregnancy specialist that specializes in what's called prenatal diagnosis. So I go through several years of extra training after I learn how to be an obstetrician, which is a doctor who takes care of pregnancies and deliver babies. So most obstetricians don't know what prune belly syndrome is if you told them. But if you told them urinary tract obstruction or if you use a different term, they would know what it is. So in pediatrics, pediatricians probably only, they may only have one patient in their entire career that has prune belly syndrome. So it's a very rare disease. So they may have never seen it before. So the only way you can make people aware of it is to do things like you're doing, because it's just like there's so many things to learn when you become a doctor that it's impossible to learn about every single rare disease. It only happens 1 in every 50,000 people. There's literally hundreds of thousands of those diseases. And if you've never seen it, it'll never stick in your head. It's like anything else in life. If once you see it, then it's hard to forget. So, the only way that you can bring recognition to something as rare as this is to have, educational seminars and blogs like you have. And there's lecture. I mean, doctors do go to lectures, but most doctors who listen to academic lectures on something like prune belly syndrome are usually one of 3 different fields. They're usually in my field. They're usually a pediatric urologist or a pediatric nephrologist, and it's touched on in some general pediatric lectures. It would be very unusual, for instance, for an obstetrician to get exposed to any kind of discussion or reading about this particular disease they do 4 years of OBGYN, and they probably never get any discussion or lectures on this particular disease because it's so rare, and they'll probably never see it in their lifetime. So to bring recognition to stuff like this, it's like any other rare disease. You need to have dedicated people like yourself to bring it to light, and you have to lobby groups to support methods to make it better and make diagnosis better. It's tough because you're a small group.
Yeah.
Yeah. Jerry, what's his name? The comedian who died from muscular dystrophy, Jerry Lewis. Jerry Lewis, spent his entire life trying to raise money for muscular dystrophy, which is also a rare disease, but it's way more common. But it took efforts like that to bring it to light. And when you have a disease that's so rare, it's really hard.
Yeah. It's funny you mentioned that because I'd say about a year ago, I teamed up with a local pastor and a township administrator, and we had a 5K raising money for the Prune Belly network.
Oh, cool.
Which, since I mentioned him, I should probably say is not sponsoring this video.
Oh, that's in full disclosure.
Yep. So, can a prune belly patient have weight loss surgery?
That's a great question. I actually don't know the answer to that because I'm not a general surgeon. I would imagine that that you probably can, because that's more about the anatomy of your stomach and your intestines. And so if you don't have a genetic mutation that also there's a condition that's similar to prune belly, that affects the intestines also.
Okay.
And and the intestines don't function and they dilate. And so in that situation, I would imagine weight loss surgery would not be possible. But in Prune Belly Syndrome, other than the difficulties doing surgery through a belly wall that's been reconstructed and had multiple surgeries, I'm certain that somebody could have what we call bariatric surgery in one form. There's several different types of surgeries, and I'm pretty certain that can happen. It just would have a little bit more risk, I imagine. But as long as the intestines are functioning normally, then there's no reason that you couldn't do that.
Okay. And for someone who wants to go down, no, I don't know if I said this, for someone who wants to go down your path and become same specialist as you, what would the track be to do that?
So, getting into medical school is the first part. And then after medical school, you have to apply to an OBGYN residency. Well, for me, OBGYN residency, and I'll tell you about a couple different tracks. After that's a 4-year program. And then you have to apply to a fellowship, which is a subspecialist in maternal fetal medicine. That's a 3-year program. So 4 years of medical school, 4 years of OBGYN residency, that's 8 years. And then 3 years of maternal fetal medicine, that's specialty training in high-risk pregnancy. So that's 11 years. And then you can go into high-risk pregnancy practice. Some people then do another 1 or 2 year fellowship in what's called fetal therapy. So this wasn't present when I was training, but now you can do an extra year or 2 in what's called fetal therapy, and those doctors subspecialize even more. And instead of just taking care of high risk pregnancies, because I take care of also mothers who have heart disease and diabetes, and I mean I have a woman who has a heart transplant. Or I have a woman who has kidney transplant. I have a woman with a liver transplant. But there's some people who go another year or 2, and they only take care of babies with birth defects inside the womb. And so that's like, so they're called fetal therapists. And so, for instance, CHOP has a group of fetal therapists now, and that's all they do. I refer my patients now to them, and all they do is take care of kids like yourself. They don't do anything else. They just take care of in utero birth defects. So it could be as long as 13 years of post high school education, 13, 14 years. That's a long path, but it's certainly for that kind of profession, it's worth it. The other track is the pediatric track. So you can go to medical school for 4 years, and then you can do a 3-year residency in pediatrics. And then you can do a 4-year residency you have to do general surgery for a couple of years. So, and then you can do a pediatric surgical residency. So that's that's a total of another 14 years after high school. So you could become a pediatric surgeon, and then you can do another 3 years and become a pediatric urological surgeon. So that's a second path, because a lot of the surgeries that you had were done by a pediatric urologist, I imagine.
Yeah.
And I know a lot of those, and they're really great people. They dedicate their lives to helping kids like yourself. There's obviously, you had a lot of surgeons involved in your care. So your belly wall was reconstructed a couple times. So that's usually a general surgeon or a plastic surgeon. So you're talking about, a pathway of approximately 14 years after high school of training. So it's a long road, but fortunately, when you become a resident, after you graduate medical school and you become a resident, even though you're still in training, you get paid to be a resident. because you're an integral, very, very important part of the medical system in big hospitals that take care of kids like you. You need the house staff, which is the residents, to not only train, but also to help make sure that the care is as good as it can be.
Yeah. So, how likely are you to recommend a channel like this to a mother pregnant with Prune Belly?
In terms, you're talking about your channel?
Yeah, where we
Oh,
have Prune Belly patients, where we have doctors and other people, parents and people like that,
yeah.
coming on and
So
telling, about Prune Belly syndrome.
yeah, so that's a great question, because so every time, so I'm always looking for ways to engage my patients, to allow them. I'm a big proponent of education. So I not only teach, I'm a professor at Penn, and
Oh,
I teach not only medical students and OBGYN residents and maternal fetal medicine fellows and other radiologists, and I give lectures to pediatricians, and I do stuff all over the country. But I'm a big proponent in patient education, because I think that if I can't express things to my patients that they can understand to make it right for them and their family, then I haven't done my job well. So I try and use forums like yours as often as I can. When I find out about them, I'm thrilled, because there's sometimes I just know that nowadays with the internet, you can almost find anything, but it's unfiltered. And so I want to make sure that whatever my patients are hearing is factually correct, and it's not biased necessarily. That's going to, because you can have, in my field, I think it's important to give what we call we use the term non-directive counseling. So what that means is, I'm not going to tell a mother that you need to terminate your pregnancy. And I'm not going to tell a mother that you need to have a baby who's going to have lifelong serious problems. I'm going to give her the facts and help her and her family make a decision that's right for them, regardless of what it is. I'm not going to be judgmental. I'm not going to put my own particular moral or ethical feelings in it, other than to say that here's what we're dealing with, here's what we can do to fix it, here's your options, and I'm going to help you guys make the best possible decision for you and your child. And using blogs and forums like you have is very, very helpful in that regard. So when I learn about it, I refer people to it as often as I can. I actually have had the opportunity to mention yours to a patient not that long ago. About 2 weeks ago, I had a woman with a similar situation.
thank you. Yeah, that's actually part of the reason I started this, because not many people's heard about Prune Belly. And aside from that, when a parent has heard about it, it's probably their very first time hearing about it.
Right.
And I wanted to create something that's unfiltered, and Prune Belly patients can come tell their side of the story. Parents could come tell their side, and doctors could come say, facts and their
Yeah.
side of Prune Belly.
Yeah. And I don't, I'm not a pediatrician, so I don't take care of all of the issues that occur after the birth. So they would be way more knowledgeable than I am about that. So my specialty is prenatal diagnosis, and then what can we do about it in the womb, and what the choices are, and how do we find out what's causing it, and how severe it is, and what you would expect to happen after birth in terms of what the lifelong issues would be. And then, but then dealing with it after birth, of course, is a different specialty, which you've probably had some pediatric people on before, I imagine.
Yeah. Yeah, I actually switched about, I think it was 2 years ago, I switched from CHOP over to Jefferson.
Okay.
And the reason I did that is because I just had bad experiences with other hospitals, including CHOP.
Yeah, you always be cautious. I mean, everybody being in a hospital situation for a lot of your life is challenging, and there's always going to be stuff that rubs you the wrong way. There's no question. It's not a fun thing to do, and there's at both places there's dedicated people that their
Yeah.
lifelong journey is to help people like yourself. But there's always going to be situations that just don't feel good, and that's a tough thing that we deal with in medicine all the time. But you know, they both do a fabulous job
Yeah.
at helping kids like yourself.
Yeah. Because like I said, I've had both bad and good there, so I know it's not all bad there. I just personally, you know what I mean? I go by my experiences, but getting off that topic, because I don't want any lawsuits or any of that against me for this. But is there anything else you'd like to add?
No, I just I just want to thank you for asking me to get on your forum, and it's really it's heartening to me to meet somebody after so many years that I only saw inside the womb and only for about 5 minutes after birth. And so, you know, I get Christmas cards every year from kids that I've delivered the different birth defects, but I actually have a plaque of you on my wall here in my office that your mom made me after you were born. I think I sent you a picture of it.
Yeah, you did.
But
really
so I have
nice.
a couple of those. I have a couple of those on my wall, so it gives me a reminder of stuff that's happened over the years. But it's special. It's special to me. So I really thank you for having me today.
Yeah. Just one more question. If you could do your career over again, would you go the same path?
Absolutely. Yep. I love what I do. It's still one of the, as I mentioned before, the thing that got me into high risk pregnancy was it was becoming a very cutting edge field, and there was a lot of new stuff happening. And I had the feeling that there was going to be like a lot of new things that we can do to help babies and to help mothers. And over my 30-year career so far, that's all come true, that there's so many more things that we can do today for high risk mothers and babies that we couldn't do back then. And I can see now that we're on the verge of another, I would say another revolution is going to happen in the next 10 years, because we're now able to fix some of these genes that are wrong inside the womb.
Wow.
And that's going to become the next frontier that we're going to be seeing happen right in front of our eyes over the next 20 years. So before I die, I'm going to see us able to actually change and fix genes inside the womb before babies are born, so that they can fix these problems on their own, which is really, really cool.
That's absolutely amazing. Sounds like a great future ahead of us.
Yeah, it's going to happen. It's just a matter of how long it takes.
Yep. All right. So again, it was a great pleasure and honor being able to speak with you again, Dr. Debbs.
Yeah, thank you so much. It's great to meet you all. Have a wonderful day.
All right, everyone. If you liked the video, don't forget to like and subscribe. We'll be back next week with another video. And don't forget to share. We're trying to get the awareness out there, and we're trying to get more people aware of Prune Belly. Hopefully, we can expedite some of the research and, well, actually freeze that, not expedite, but get more funding for some of the research. And I'll see you next time.
For a long time, I seemed unique from a very early age, asking why, feeling weak, living within a cage, wondering if I am the only one.
What was I supposed to make of my limitations? How much more should I take of this situation? Can it be I am the only one?
The only one. The only one.
All throughout, I found out what love's about, leaving no doubt I'll survive, channel the drive, not deprived.
different. At times, you think you are the only one who exists with the pain of not being the same. When you got brothers and sisters that don't share the same last name or share the same blood, but share the same battle. Some days are real good, some days are just a hassle. Operations to doctor visits, you are not alone. So I wrote this to let you know you don't have to be alone.
The only one.
You don't have to be
The only one.
You don't have to be alone.
These days, there are ways through the haze to sing his praise. We gather here with prayers held dear, wanting to erase all pain, death, and fear. Lord, please help them see. No one seems to have heard just how this came to be. We need to spread the word.
Show the world I'm not the only one. No, no. Thank you, Lord. Thank you, Lord, for this community. Thank you, Lord. Thank you, Lord, for the thread we share. Thank you, Lord. Thank you, Lord, for this unity. Thank you, Lord. Thank you, Lord, for the power of care. Thank you,
The
Lord.
Prune Belly Syndrome Network is a volunteer organization devoted to patient support and education of the medical community about this rare condition.
1 in 40,000 live births result in Prune Belly Syndrome, and all of them have all or some of their abdominal muscles missing.
50% will not survive their second birthday.
Our goal is to change the medical profession's perception of Prune Belly Syndrome as a hopeless condition
and to educate and promote an interest among the community to do further research into the causes of the syndrome
and more effective treatments.
www.prunebelly.org.
You can help.
Thank you, Lord, for this community. Thank you, Lord. Thank you, Lord, for the thread we share. Thank you, Lord. Thank you, Lord, for this unity. Thank you, Lord. Thank you, Lord, for the power of care. Thank you, Lord, for showing me I'm not the only one.
If you don't know what Prune Belly is, please go to www.prunebelly.org